At the start of the transthoracic echocardiogram, the indications for study are reviewed, along with any relevant information from the patient's chart, for example, prior cardiac surgical procedures. For follow-up studies, the images and results of the previous exam are briefly reviewed. The ECG leads are placed on the left and right shoulders, and the patient's left side, a lead 2 orientation, and the ECG signal is adjusted to ensure the QRS is well defined and higher than the T wave. A suboptimal ECG signal may lead to incorrect triggering of cine loop image acquisition. Height, weight, blood pressure, and heart rate are recorded before starting the exam. The patient is asked to turn into a left lateral position with the approximate location of the cardiac apex over the cutout on the stretcher, and the patient's head comfortably supported with a pillow. The sonographer sits at patient's left side on a wheeled stool with the height and positioning adjusted to allow access to the instrument panel with the right hand, while holding the transducer on the patient's chest in the left hand. Appropriate instrument settings are selected at the beginning of the study and then adjusted as needed for image and Doppler data acquisition throughout the examination. We typically record 2 beat cine loops, reverting to time-based acquisition with very irregular or rapid rhythms. The image depth is adjusted to include the anatomic areas of interest from each acoustic window, and image quality is optimized using the time gain compensation, in addition to focal depth, overall gain and power, tissue harmonic imaging dynamic range, and other instrument controls as needed. During the exam, the image frame rate should be at least 30 per second. Frame rate can be increased by decreasing depth or narrowing the image sector. A multi-frequency imaging transducer is selected. Higher imaging frequencies provide the best resolution, but lower frequencies may be needed for adequate tissue penetration, particularly in larger patients or for structures distant from the transducer. Ultrasound gel is used to ensure acoustic coupling between the transducer and the patient's chest. The tomographic image plane is oriented along the plane identified by the mark on the transducer. The motion of the transducer during imaging is referred to as move when the position on the chest is changed, tilt for motion within the same image plane, angle for image planes lateral and medial to the original plane, and rotate for a circular motion of the image plane. The basic exam starts with the parasternal window, with the transducer placed in the 3rd to 4th intercostal space just to the left of the sternum, the image plane adjusted to intersect the center of the aortic and mitral valves. First, the parasternal long-axis view is recorded at maximum depth to show posterior structures such as the descending aorta. Then the image depth is decreased to include only the cardiac structures. In this view, we see the aortic sinuses, aortic valve, mitral valve, a small portion of the right ventricular outflow tract, the basal anterior septum, and the basal posterior left ventricular wall. This view is useful for detection of aortic and mitral valve disease, dilation of the aortic sinuses, and measurement of left ventricular systolic and diastolic chamber dimensions and wall thickness. An M-mode recording of aortic valve motion can be made by aligning the M line at the aortic leaflet tips in the long axis view. The M-mode recording shows the parallel motion of the aortic walls with the leaflets opening in systole and the left atrium posteriorly. An M-mode recording also may be useful for measurement of LV wall thickness and dimensions when the M line can be aligned perpendicular to the long axis of the LV. The transducer then is rotated clockwise 90 degrees to provide the left ventricular short-axis view at the level of the papillary muscles. This view shows LV size, wall thickness, and systolic function, and also is useful for evaluation of regional wall motion. Beginning at 12 o'clock and going clockwise, we see the anterior septum, anterior wall, lateral wall, inferior lateral or posterior wall, inferior wall, and inferior septum. Keeping the transducer in the short-axis plane, but moving towards the cardiac base, we next record the mitral valve short-axis view, showing the right ventricle anteriorly, the basal left ventricle, and the anterior and posterior mitral valve leaflets. The transducer is moved or tilted further towards the cardiac base to obtain an aortic valve short-axis image, which shows the 3 leaflets of the valve in the center of the image. Starting from the right atrium and going clockwise, we see the tricuspid valve, right ventricular outflow tract, and pulmonic valve. The left atrium is located posteriorly with the atrial appendage seen in this patient adjacent to the pulmonary artery. Next, the image plane is tilted towards the patient's right side to show the right ventricular inflow view with the right atrium, tricuspid valve, and right ventricle. The entrances of the coronary sinus and inferior vena cava are seen medially. The right ventricular outflow view is obtained by tilting the transducer towards the patient's left shoulder to show the RV outflow tract and pulmonic valve. In the parasternal views, the standard Doppler exam includes color flow imaging in the long axis view for detection of aortic and mitral regurgitation and to detect any flow disturbances such as subaortic obstruction or a ventricular septal defect. Flow towards the transducer is shown in red. For example, the normal left ventricular ejection of blood across the aortic valve. Flow away from the transducer is shown in blue. Doppler color flow images also are recorded in short-axis views. This example at the aortic valve level shows normal systolic flow in the pulmonary artery in blue and a physiologic amount of pulmonic regurgitation in red. Pulse Doppler velocity recording with the sample volume just proximal to the pulmonic valve shows a normal systolic ejection curve with a peak velocity about 1.0 meters per second. Using the continuous wave Doppler mode, the diastolic curve of pulmonic regurgitation is seen in addition to the antegrade flow velocity curve. The tricuspid valve is evaluated with color Doppler in the RV inflow view, with visualization of the very small regurgitant jet assisting in recording the continuous wave Doppler velocity signal. In this normal individual, the signal is too weak for accurate measurement. When a clear signal is obtained, the maximum velocity is used to estimate pulmonary artery systolic pressure. After completing the parasternal views, the cardiac apex is located and the patient positioned with the apex over the cutout on the examination stretcher to allow placement of the transducer on the apex with free motion of the transducer as needed to obtain diagnostic images. Again, ultrasound gel is used to provide acoustic coupling between the transducer and the patient's skin. The apical 4-chamber view is obtained with the transducer on the left ventricle apex. The convention for echo images is to show the transducer position at the top of the image because this allows correct identification of ultrasound artifacts. Image quality often is improved by having the patient hold his breath at held expiration. Thus, in the apical views, the LV apex is at the top of the image, with the LV on the right side of the screen, with the inferior septum and lateral LV walls well seen. The right ventricle, RV, on the left side of the screen, and the left and right atrium in the far field of the image. The 4-chamber view also shows the mitral and tricuspid valves. With anterior angulation of the image plane, the aortic valve is seen in a view nicknamed the apical 5-chamber view. This view is useful for recording LV outflow and transaortic Doppler velocities. From the 4-chamber view, the image plane is rotated clockwise about 60 degrees to obtain the apical 2-chamber view. We now see the anterior LV wall on the right side of the screen and the inferior wall on the left side of the screen. The mitral valve image includes the anterior leaflet. If the image is tilted slightly posteriorly, both the anterior lateral and posterior medial papillary muscles are seen. Further clockwise rotation by another 60 degrees provides the apical long-axis view. The anatomy of this view is analogous to the parasternal long-axis view with the anterior septum and posterior or inferior lateral left ventricular wall, the anterior and posterior leaflets of the mitral valve, and the aortic valve all well seen. For calculation of left ventricular ejection fraction, images are recorded in the apical 4-chamber and 2-chamber views with the image depth adjusted to include only the left ventricle and instrument settings adjusted to optimize visualization of the endocardial borders. When needed, ultrasound contrast is used to enhance identification of the endocardial borders. These images are traced at end diastole and end systole for calculation of LV volumes and ejection fraction. Three-dimensional or 3D imaging also can be used for measurement of ejection fraction. A 3D volumetric image of the left ventricle is obtained. 3 orthogonal image planes are defined and anatomic landmarks are identified. Then, automated software using speckle tracking methods generates LV borders throughout the cardiac cycle with measurement of LV volumes and ejection fraction. After visual confirmation and adjustment as needed, the display shows regional wall motion using a color map and graphical format. Color Doppler images are recorded in the apical views to evaluate the mitral valve in the 4-chamber view, as shown here, as well as the 2-chamber and long-axis views. The aortic valve is evaluated in the 5-chamber view and long-axis view. The tricuspid valve is imaged with color Doppler in a 4-chamber view tilted towards the right ventricle. Pulse Doppler recordings from the apical view include left ventricular inflow curves recorded in the apical 4-chamber view with the sample volume placed at the mitral annulus or leaflet tips. The spectral Doppler tracing shows early diastolic filling, the E velocity, and the atrial contribution to filling or A velocity after the ECG P wave. The left ventricular outflow curve is recorded in the 5-chamber or apical long axis view with the sample volume position just proximal to the aortic valve for LV outflow tract flow and distal to the valve for aortic flow. The pulse Doppler recording of LV outflow shows a systolic ejection curve with a peak velocity just over 1 meter per second. Pulmonary venous flow is recorded with the sample volume positioned in the right superior pulmonary vein in the 4-chamber view, followed by pulse Doppler recording showing the normal systolic and diastolic inflow curves, along with the slight reversal of flow with atrial contraction. Tissue Doppler velocities can be recorded after adjusting instrument settings with the sample volume positioned in the basal septum adjacent to the mitral annulus in the 4-chamber view. The recorded tissue Doppler signal shows the early diastolic motion of the myocardium away from the transducer, called E', followed by the myocardial motion after atrial contraction, called A'. Continuous wave, or CW Doppler, from the apical windows include recording of transaortic flow for measurement of peak velocity and detection of aortic regurgitation, transmitral flow for detection of mitral regurgitation, and tricuspid valve flow for measurement of the maximum velocity of regurgitant flow for calculation of pulmonary pressures. Now the patient is asked to lie on his back with knees bent to relax the abdomen if needed for imaging from the subcostal window. The subcostal 4-chamber view is obtained with the transducer oriented towards the patient's left shoulder. The liver is seen closest to the transducer, with the right and left ventricles, right and left atrium, and both atrioventricular valves well seen. This view is particularly useful for evaluation of right ventricular size and function, and for examination of the atrial septum. Subcostal views also may be helpful when other acoustic windows are suboptimal. The transducer is turned posteriorly and laterally to show the inferior vena cava as it enters the right atrium. The vessel size and changes with respiration allow reliable estimation of right atrial pressure. With the transducer turned medially, the proximal abdominal aorta is seen, allowing evaluation of flow patterns and aortic dimension. For the suprasternal notch window, the pillow is removed and the patient's head turned towards the side. With the transducer placed in the suprasternal notch, a long-axis view of the aortic arch is obtained. The right pulmonary artery is seen in cross-section under the arch. Color Doppler imaging shows normal flow in the aorta. Because Doppler data are angle-dependent, flow in the proximal arch is shown in red towards the transducer, and flow in the descending thoracic aorta in blue, away from the transducer. Pulsed or continuous wave Doppler recording of flow in the descending thoracic aorta is useful in evaluation of aortic regurgitation, aortic coarctation, and patent ductus arteriosus. When the examination is complete, the ECG leads are removed, gel is cleaned from the chest, and the patient is ready to leave. The sonographer then completes measurements and image selection and prepares the study for physician review. The physician reviews the images, ideally with input from the cardiac sonographer, prepares the final interpretation, and communicates the results to the referring healthcare provider.